Okay, assalamu alaikum everyone. My name is Shahad Murshid. I'm a second year, and today, inshallah, we'll be talking about urine concentration and dilution. Now, this session, as I heard from some of you, is kind of difficult when you first try to approach it, and that's exactly the reason why I decided I wanted to teach it, because I also remember me taking it in my first year, and it was very hard for me in the beginning, and it seemed very confusing and overwhelming. But the moment I understood it, like everything clicked for me, and I loved the I loved how everything had a reasoning to it. It wasn't just it all made sense basically. So I really want to make it make sense for you guys. And so this session is going to be very interactive. I have a lot of questions throughout the session. So I'm really sorry if the recording ends up being long. If you're watching the recording, don't make this don't click out of the video if you see it long. You can easily skip through the interactive part if you don't want that, but inshallah my explanation will be concise and to the point, and it won't take you too long to get through the recording. Okay, so without further ado, bismillah, let's get started. Okay, so these are our learning objectives. Basically, I'm not going to read the learning objectives, but I do want you to know the main thing that we're going to be getting from this lecture, and that is we want to make concentrated urine. Okay, so we don't want our urine to be dilute. So we're going to see all the factors that play into making urine more concentrated. This includes things like the Vasa recta blood flow and ADH, and we're going to look at all of them throughout this session, inshallah. And yeah, so let's just get started. So before we start, I do want to review some terms. So all of these terms, you have been exposed to them before, either in foundation or in the beginning lectures of your renal block. So you should be familiar with all of them, but they're all very, very important in order to understand this lecture. So the first one, or let me go to the first three. First three, excretion, absorption, and secretion. This was very confusing for me in first year. I used to always get them mixed up, but essentially it's very easy to differentiate between them. So excretion, you're excreting something out of the body. So the way urine leaves the body is through excretion. So when something leaves the body, it's excretion. So as the definition says, removal of waste products from the body through urine. Now, absorption, how I like to think of absorption and secretion is think about it from the point of view of plasma. So are you removing things from plasma, or are you taking things into plasma? If you're absorbing, you're taking into plasma. So you're moving things from the nephron to plasma. Okay, I hope that makes sense. So in the context of the kidney, at least, when we say absorption, we basically mean that we're taking things into the plasma. So we're removing it from the nephron. Now, when we say secretion, it's the opposite. We're taking something from plasma and we're putting it into the nephron or the cell, or in this context, we're talking about the nephron. So I'm going to keep going with that. So yeah, secretion, movement of substance from plasma to nephron. Simple enough. Now for osmolality and tonicity, you're gonna hear it so many times during this lecture. So having a good basis on these two terms from now is gonna make the lecture so much easier. So again, you took this in foundation, but osmolality is basically how many particles you have in a solution. So the more solutes you have, like sodium or chloride or any solute that you have that is in a solution, the more you have of that, the more the osmolality increases. So if you have high solutes in a concentration, we call that hyperosmolar. And if it's low, we call that hypoosmolar. Okay? And then for tonicity, it's basically the pressure that solutes have on water movement in and out of the cell. So if you have a low tonicity basically means low solute concentration. So if you have low tonicity in a solution, you're basically going to make water want to leave that solution. Okay, so it basically pushes water. It dictates whether water goes out of a solution or into a solution. Okay, so if you have if you have low tonicity, by the way, this means that the solution is more dilute. That means that it has a lot of water. This is basically what hypotonicity refers to. It means that the solution is very dilute. So logically, what's gonna happen is water is gonna want to leave that solution. Okay, so tonicity is referring to the water movement in and out of the cell. Low tonicity, while water is going to leave the cell. High tonicity, water is going to come into the cell to help dilute it. If it has high tonicity, that means it's very concentrated. Okay, I really hope this concept is clear. If it's not, please let me know now and I'll repeat any part of it, because as I said, this is sort of like builds a foundation for the rest of the lecture. Okay, so again, this is a picture that you've probably seen before. It's basically just the concept of osmosis. So if you have this segment, this part has low solute concentration, and this one has high solute concentration. So logically, water is just going to move over here. So it's basically moving from a hypotonic to a hypertonic compartment. Okay. So I'm going to just test everything I just said with these little schematics that I made. So this this concept right here of solutes moving from the nephron to plasma, what does this illustrate? Can one of you tell me? Perfect. Absorption or reabsorption. Okay, what about this? Secretion, yeah. Great job. Okay. And here, is the plasma hyperosmolar or hypoosmolar to the nephron? We're talking relativity here. So in relation to the nephron, the plasma, is it hyper or hypo? Ima, do you want to rethink your answer? Hyper or hypo? Okay, so it is hyper. Okay, hyper refers to the number of solutes that we have. So the more solutes that we have in a solution, the more hyperosmolar it is. Yeah, exactly. It means solutes, not water. Yeah, exactly. You're perfectly right. So this solution would have more, since it has more solutes. Or no, it would have. Yeah, exactly. You get the point. Okay, so over here is the plasma hypertonic, hypotonic, or isotonic to the tubular fluid. So the plasma in relation to the nephron or the tubular fluid. Exactly, it's hypotonic. So in this case, which direction is water going to move? Is it going to move into the nephron or out? Perfect. It's going to move into the nephron. You guys are perfect, mashallah. So yeah, you have a low solute. We know that the water moves from a low solute concentration to a high solute concentration. Okay. And here is the plasma hypertonic, hypotonic, or isotonic to the tubular fluid. Iso, perfect. Okay. So again, this is also another review before we get into the actual lecture. This just shows you like the structure of the nephron that you've taken before. I mostly just want to focus on this part. This part. This is our whole lecture is going to be looking at this. We're not going to look at the beginning part at all. So we have the loop of Henle. The main thing that you want to note here is the descending limb is permeable to water. The ascending limb is permeable to solutes like salts. Okay. And also note the different zones of the renal tissue. We're going to be talking about this a lot, so I do want you guys to be oriented with them first. The cortex is the outermost layer, and then you go the outer medulla, and then the innermost is the inner medulla. Okay. Another thing is this vascular network that you have around the loop of Henle, which is called the Vasa recta. This is also going to play a major role in, or not major role, but it is going to play a role in concentrating urine and our whole goal with this process that we're going to have. Okay. So the Vasa recta is basically this network along with the peritubular capillaries. They are going to help remove things from the nephron, basically. Okay. Now let's get started with the actual lecture. So, Bismillah. So, as we know, our body produces a lot of waste products every day. Okay, this is a normal thing. We have many waste products that get produced, such as urea, drugs, or creatinine, whatever it is. And the quantity in which these drugs are produced is about 1,200 milliosmoles. So our body is gonna want to excrete all of that. It wants to remove all of it from our body. But here's the catch. If it were to remove it in the same concentration or in the same osmolality that plasma is, which is 300 milliosmoles, we would be excreting 4 liters of urine a day, which is like a lot. It's too much for our body to handle. Like our body can't be excreting that much urine. The maximum that we excrete is about 2 liters. It's like from 0.8 to 2 liters. So we don't want to be excreting 4 liters of water. No way. So how does our kidney combat that, basically? It's going to concentrate the urine. So it's going to remove water from the urine so that we have less water being excreted. Makes sense. Okay? So how are we going to do that? How are we going to create a hyperosmolar urine? Okay, this is our goal, to make a hyperosmolar urine. How are we going to do that? We have 2 different steps. Number 1 is we're going to create a hypertonic interstitium. Number 2, we're going to concentrate it by something called a countercurrent multiplier. I know this makes no sense. We're gonna look at it step by step now. So this is the image that you have in your lecture, and it is, I know it's very overwhelming at first. There's just numbers everywhere and tubes going all around. Makes no sense at first glance, but don't worry, we're gonna look at it one by one, and we're gonna make it make sense. Over here also I linked a video. Wait, can you guys see my, okay, never mind, you cannot see it. Okay, so this video, it's like a 4-minute video. It basically just illustrates the whole thing for you. If you have time and you want to take a look at it, I think it'll be really helpful. It helped me a lot in first year. Okay, so before we get into everything that's happening here, let's orient you to what exactly we're looking at. So right off the bat, you see this structure that looks like a loop. You know, we're looking at the loop of Henle. And this is the descending limb. The descending limb is going down. Basically, it's going like this. This is how like fluid moves from this, like goes like this. Okay, so you have the descending limb, and then you have the thin ascending limb, the thick ascending limb, and something to note, again, like I said earlier, the descending limb is permeable to water. The ascending limb is only permeable to solids. It is not permeable to water. So water cannot leave the ascending limb at all. This is going to be really, really important later. So keep this in mind. Again, this is the interstitial fluid, and this is the tubular fluid. Okay, now when we know all that, let's look at what basically happens in each segment. So the starting point, okay, basically, what's happening is fluid is moving all throughout the nephron. Okay, so the part right before the loop of Henle is the proximal tubule. So the fluid is going to be coming in from the proximal tubule and going into the loop of Henle. So the fluid in the proximal tubule, as you probably know from previous lectures, is 300 milliosmoles. It is isotonic to plasma. So when it comes in, initially in the loop of Henle, it's isotonic to plasma. So as you can see, they're all 300. Obviously, we don't want that. We're going to change that, which is what we're going to see in the other steps. Okay? So this is just like a little quiz for you guys. I said that the osmolality of the tubular fluid, the interstitium, and plasma are all the same. So how would we describe the urine in relation to plasma in this point? The osmolalities are the same. What would we call it? Isotonic, perfect. So the urine is isotonic to plasma and the proximal tubule. Okay, now moving on to the next point. This is actually the beginning of the cycle. Okay, this is the first thing that the nephron does, or the loop of Henle does. The main goal of this whole part is we want to create a 200 milliosmol gradient. What does this mean? We basically want a difference of 200 between the ascending limb and the interstitial fluid. So initially, they're both 300. Okay, you have 300 here and 300 here, milliosmoles. In order to make it, in order to make a 200 milliosmol difference, what happens is, I'm gonna use it here. Okay. So here you have 300 and here you have 300. Okay. What you want to do is, this is the ascending limb and this is the interstitial fluid. Okay. So basically what you want to do is you want to make a 200 milliosmol difference. So what happens is the ascending limb pumps out solutes, like salt, okay? So it's gonna pump out 100 milliosmoles of salt. Now, if it removes 100, basically what's happening? It's losing 100. So if it was 300 and it lost 100, it became 200. And the interstitial fluid is gaining 100. So it became 400. Now, as you can tell, we created this 200 milliosmol difference. So this is essentially what's happening here. We said that the ascending limb is permeable to solutes, okay? So in order for it to make this 200 milliosmol difference, what's gonna happen is solutes are going to leave the ascending limb, okay? So this is what's happening. Like, this is what these arrows are showing you. They are basically, solutes are leaving the ascending limb, going into the interstitial fluid, and making the interstitial fluid more hyperosmolar. Again, this was one of our goals in like the first steps that I mentioned. We want to make a hyperosmolar interstitium. So this also plays a part in it. Okay, so we're making the interstitium, basically, it went from 300 over here to 400 over here. So you'll notice that as we progress, it's going to get more and more hyperosmolar. Okay, so here we have, now this is 400 milliosmoles and this is 200 milliosmoles. Okay, let me just make sure I didn't miss anything. Salt is pumped out. Interstitial fluid osmolality increases, ascending tubular fluid osmolality decreases, and we created a difference of 200 milliosmoles. Okay, is this part clear? You guys want me to re-explain anything, or do you understand what's happening? Okay, perfect. Okay, so now we're reaching the second step. So in the second step, what we want to do is we want to make the descending limb and interstitial fluid have an equal osmolality. So how are we going to do that? As we know, the descending limb is permeable to water. Okay, so let's say this is the descending limb. At first, in the step earlier, it had an osmolality of 300, and this had an osmolality of 400. Now, again, this just goes back to the basic concept that we said earlier. This, if it has a osmolality of 300, this means that it has low solutes. And this has higher solutes. So again, water, how is it going to move? It's going to move from the area of a low solute concentration to the area of higher solute concentration. So this makes perfect sense to everything that we know so far. So this is why water is going to be leaving the descending limb in order to equilibrate with the interstitial fluid. Okay? And yeah, so the increased osmolality in the interstitial fluid causes water to move from the descending limb into the interstitium until the osmolality of the descending tubular fluid equalizes the interstitial osmolality, exactly what we said. By the way, I put everything in the slides here so that you can like fully depend on these. All of Dr. Shams's notes are here as well. Okay, now moving on to the third step where we are basically gonna shift everything. So as we know, like fluid is moving across the nephron, right? So logically, new fluid is gonna come in and it's basically just gonna push everything like one unit forward. So 300 was here, it's gonna come here. 400 was here, it's gonna come here. And that's just basically what we're seeing happen here. So new fluid from the proximal tubule enters the tubule and pushes the fluid forward. And this is basically going to change the osmotic equality that we like formed earlier. And this gets recognized by the pump. So the pump is going to want to You know how we had like a 200 milliosmol difference in everywhere in the ascending limb and the interstitial fluid? Over here, as you can see, this kind of disrupted that sort of the difference that it was trying to maintain. So what's going to happen is the pump in the ascending limb is going to recognize that, and it's going to start pumping out more salt in order to maintain that 200 milliosmol difference. Okay? That's basically all that's happening in this part. So we're just shifting the fluid, and as a result of that, everything that we formed earlier was kind of being disrupted. So the kidney is just going to try to fix that. It's going to just do the same things again. It's going to try to maintain that 200 milliosmol difference, and it's going to try to maintain that equality between the descending limb and the interstitial fluid. Does that make sense? Are we good so far? You guys have any questions? Yes, the process repeats again to make it more hyperosmolar. Okay, because this over here, this is not concentrated enough. By the way, we're not even done with the whole process. It's gonna get even more concentrated. So the whole point of us doing this over and over and over again is look at the original picture. Like I said, it gets progressively more concentrated. Here it was 400, then it was 500. Now it's at the end, it's going to be 1,200, which we didn't even reach that part yet. But just to show you, it gets more and more concentrated as you go. And basically what's happening is this cycle is just getting repeated. The 200 milliosmol gradient and the reaching the equilibrium between the ascending limb and the descending limb and the interstitium. This is going to keep repeating. And the numbers are going to keep getting higher and higher and higher. Okay? Hope that's clear. Okay, so I'm going to ask you guys a few questions just to make sure that we're on the same page. So which segment of the nephron contributes the most? Okay, I'm sorry, there's a question. So in the third step, the pump pumps the salt in the tubular fluid. No, this is the tubular fluid. This is the tubular fluid. The pump is taking it out of the tubular fluid. Oh yeah, it pumps the salt that is in the tubular fluid into the interstitium. Okay, to keep this 200 milliosmol difference. Does that make sense? Okay, perfect. Okay, so let's just look at a few questions. Which segment of the nephron contributes the most concentrating urine? By the way, I didn't explicitly say this, but it's basically what we're talking about this whole time. Like, which segment of the nephron are we looking at? In general, like not even specific. Because the solute more, the descending of first water too. Yeah, exactly. The answer is loop of Henle. Hold on, because the solute is more in the interstitial fluid, the descending will push water into exactly Sikra. So here in the interstitial fluid, as long as if the interstitial fluid has more solutes, that means that it's more concentrated. Okay? And the descending limb is less concentrated. It's more dilute. If it's more dilute, that it means that it has more water. So if it has more water to give, why not give it to the interstitial fluid? Right? So it's exactly what you said, yes. Does that make sense? I want to get a yes. If not, let me know. Perfect. Okay. So yeah, you guys answered this perfectly. So describe the tonicity of the fluid coming into the descending limb in relation to plasma. So the initial fluid that came in. What was the relation of it to plasma? Was it hypertonic, hypotonic, isotonic? Iso, yeah, perfect. This was the first thing that we saw of fluid coming in from the proximal tubule into the descending limb. And we know that the fluid in the proximal tubule is isotonic to plasma. So the fluid that is initially coming in is isotonic to plasma. Okay? That's it for the questions for this part. By the way, I'm really like trying to emphasize on the things that will be asked about more and the like more high yield concepts in my questions. So when I ask you something, know that this is like really important. Okay. Okay, now let's move on to the second cycle. Again, in the second cycle, everything just repeats again. So I'm gonna go over it like a little bit quicker this time. But if you guys have any questions and you want to stop me, please do, and I'll repeat. I don't mind at all. So again, here what we want to do is we want to create a 200 milliosmol difference. Okay, this is the goal here. So yeah. So you have 300 and 500. This is a 200 milliosmol difference. How is this gonna happen? How is this 200 milliosmol difference maintained? It's basically by solutes going from the ascending limb to the interstitial fluid. Okay, because we said the ascending limb is permeable to solutes. It's permeable to salt. So salt is gonna leave the ascending limb, go into the interstitial fluid, and create this 200 milliosmol difference. Now that we have this difference, if you look here, basically, you can look at this part. The fluid in the descending limb is hypoosmolar to the fluid in the interstitial fluid. Okay, so it's more, it has more water, it's more diluted. So what is gonna happen? Since the descending limb is permeable to water, water is simply gonna move out in order to reach this equilibrium. Okay, so think of it like the goal of the descending limb. The goal of the descending limb is to have an equilibrium with the interstitium. Think of it like that. And the goal of the ascending limb is to create a 200 milliosmol difference. How does it create that? By pumping out salt. How does the descending limb reach equality with the interstitial fluid? By pumping out water. Okay? And exactly, by pushing out water. Perfect. So as you can see, and then this again gets pushed out. We have like more coming in, it gets pushed out. Literally same thing happens again. You see how it's like actually very simple and very straightforward. They're very basic topics that you have to know. It's just the whole diagram altogether looks a bit overwhelming. So never let that scare you. Okay, now let's just look at the last part. This is the last part. Okay, this is when we reach, this is the maximum osmolality of the interstitial fluid that we can reach, 1,200. Now, again, notice that the fluid in the interstitium, it actually follows a gradient. So it gets progressively more and more concentrated as you go down the interstitial fluid. Okay, so way deep down into the descending limb, and like basically the inner part of the nephron, as I told you earlier, was the inner medulla. Okay, so this inner medulla basically has the most hyperosmotic fluid. Okay, so the fluid increases towards the medulla. So as you go down, cortex, outer medulla, inner medulla. As you go into the medulla more and more, it increases. Okay, and it's equal to an osmolality to the descending limb. This is also like important to note. So the descending limb and the inner part of the interstitium, they have the same osmolality by the end of everything that we just talked about. Okay, and the ascending limb over here, you can see basically it's decreasing as you go up. So what's like the next step after the sorry, did I say descending limb? I meant ascending. So as you go up the ascending limb, it's getting more and more dilute. So the osmolality is decreasing as you go up. So when it reaches the second part, which we're going to talk about, where it goes into the distal tubule, it's actually a very, very low osmolality. Okay, so it's very dilute. That's like all you need to know here, basically. So number one, the interstitium is most concentrated in the inner medulla. It is most hyperosmolar. And then as you go like up in the ascending limb, the osmolality decreases more and more. And it's the least, it's like the lowest at the end of the ascending limb. Is that clear? Does that all make sense? You guys like understand it. It's not just, as I said, it's not just memorizing. It makes sense when you think of the whole process happening. You can predict how hyper or hypoosmolar everything is in the tubular fluid in the interstitium, just by understanding the first process that we talked about. Okay, these are literally, like, this is how questions can be asked, by the way. They're very straightforward if you understand. Like, they could just ask you, where is tubular interstitial fluid most concentrated? Or where is it the most hyperosmolar? And it's just the inner medulla. If you understand it, if you picture high osmolarity at the end of the descending loop and low, yeah. Sorry, did I say the opposite? It's high. Oh, okay, you're just clearing it up. Yeah, exactly. Yeah, you're rechecking. Yep, exactly. So at the end of so fluid is going down the descending loop. So at the end of the descending loop, it is very, very hyperosmolar. And then at the end of the ascending limb, it is hypoosmolar. Perfect. That's a really good way of summarizing it. And a good way of thinking of it too. So basically, like, if you think of the osmolarity of throughout the tubule in terms of a graph, it would be like this. We're gonna actually see this graph later. But basically, if you think of it as like, it starts to increase and then it reaches its peak at the end of the descending limb over here towards the inner part of the medulla. It's going to reach its peak and then it's going to go back down once it's leaving the loop of Henle. Okay? Now, equilibrium, salt. Oh yeah, this is an important concept. I wouldn't say it's the most high yield, but you just know it in case. So the vasa recta, as I said, it is the like vascular network that is surrounding the loop of Henle. So any solutes that are excreted or not excreted, sorry, see, I just mixed up terminologies, not excreted, that go into the interstitial fluid, these are going to be carried away by the vasa recta. So the vasa recta is basically responsible for carrying solute away from the nephron in order to like keep this process going, in order to help the urine become more concentrated. Because if it just stays the same, if the osmolality stays the same, no movement is going to occur. So it basically helps to like maintain and modify all of everything that we just talked about, basically. So the vasa recta does that. You don't really have to know the exact mechanism of it. But yeah, the vasa recta basically plays a role in maintaining and modifying a hypertonic interstitium. So if you think about it, if you have an increased blood flow in the vasa recta, if lots of blood are moving, lots of blood is moving in the vasa recta, this is going to increase the solutes that are carried by the vasa recta. So if more solutes are carried by the vasa recta, that means we have less solutes in the interstitium. Therefore, reducing the tonicity of it, basically. So we're going to make it more hypoosmolar. We're going to make it more diluted. So the higher the vasa recta blood flow, the lower the tonicity of the interstitium. Does that make sense? You guys understand the vasa recta, what it does? Okay, yeah, for sure, I can repeat that. So think of the vasa recta as something that, okay, so you have, let's just imagine the vasa recta is like something here. Okay, it is surrounding the tubular, the loop of Henle. Okay, so any solutes that are here, let's see sodium. Let's see here we have a lot of sodium that is being pumped out from here. What the vasa recta is going to do is it's going to take this sodium, it's going to take it in, it's going to reabsorb the sodium that comes out into the interstitium, and it's gonna basically just remove it from the kidney. It's gonna take it to other parts of the body, and this basically just helps to like keep the process going of if you have more sodium leaving the interstitium, you'll have a more dilute interstitium. Sorry. You'll have a more dilute interstitium basically. So you're gonna push out more sodium in order to concentrate it even more. So you're just gonna want to keep doing that because we want to make it as concentrated as possible. So all the vasa recta does is it carries solutes out of the interstitium if needed. If, for example, you have too many solutes, it's gonna take that away, and it's gonna take it to other parts of the body away from the nephron, basically. Okay, so it carries solutes away from the nephron. In turn, from the interstitium, sorry, not the nephron, from the interstitium specifically. So the interstitium is gonna become more hypotonic or hypoosmolar or dilute. It's gonna become more dilute. Yes, of course. What's your question? Okay, sorry guys, just waiting for the question. If vasa recta takes the solutes away, it makes the interstitium more dilute, making it hypoosmolar. But we don't want the interstitium to be, but don't we want the interstitium to be hyperosmolar? Yeah, exactly. That's why I said it's only when it's needed. So, like, it's gonna take stuff, like if, how do I explain this? So picture it not being 1,200, okay? Like think of it, and we're still in the early stages where we have like 200 and 100 osmolality inside the interstitium. Okay, so the driving force to move water. Hold on. I'm really scared that I'll confuse you if I try to explain this. Just know that the vasa recta like helps to maintain and modify the interstitium, the hypertonic interstitium. We don't want it, the goal is not to make it hypertonic, you're right, hypotonic. But if we don't want, you know what, I'll come back to you about this later, okay? No, it's okay, it's fine, I get it. I know why you're thinking about it so much. Like I would also have that same thought process. But just think of it in the kidney, basically, if we didn't need it to be that hypotonic, then we would decrease the blood flow, simply. So the vasa recta doesn't always have to be working at a, it doesn't always have to have a high blood flow. If the interstitium is too hyperosmolar, for example, or too hypertonic, simply we could have an increased blood flow in order to carry salts away. And if it didn't have enough, if it needed more solutes to be pumped into the interstitium by the ascending limb, then the blood flow would decrease. Okay, it's not going to want to take solutes out. Does that like make a little bit of sense? Are you sure? Okay, I hope so. Inshallah. Sorry if I confused you or anything. Just know what's written here. Mostly it's, and you're not going to be asked outside the scope of this. And Dr. Shams didn't explain it that well even at all. So I don't think he wants you to know it in detail. I watched your recording. He didn't really explain it. So urea also contributes to having a hyperosmolar interstitium. We're going to talk more about urea later, but just know that it does help with making a hyperosmolar interstitium. So we basically have two things here that made a hyperosmolar interstitium. We have urea and we have the vasa recta. It was helping this whole process, basically. Okay? Urea is going to be related to antidiuretic hormone later, so we'll talk about it, don't worry. So yeah, the final outcome of this whole cycle is that we wanted to create a the fluid that left this is what we're talking about. The fluid that left the ascending limb is hypotonic to plasma. Okay? So when we go into the distal tubule, at this point, we have a hypotonic plasma. Sorry, just give me like 2 seconds. Sorry, I just turned on the AC. Okay. So, are we still good? Is everything making sense? I'm gonna ask questions now. But till this point, does everything make sense? Perfect. Okay. So, number 1, describe the tonicity of the fluid leaving the ascending limb in relation to plasma. Okay, I literally just said this. That was bad placement of a question. So how would it would be hypotonic. Hypotonic to plasma. Okay, because it is more diluted. Again, okay. What is important in modifying and maintaining a hypertonic interstitium? Again, I also just said this. Yep, Vasa recta. And what else did I say? I didn't really like emphasize on this because it is mentioned. Okay, it's urea. It's Vasa recta and urea, basically. Yeah, urea, exactly. Okay. So would a low Vasa recta blood flow increase or decrease the tonicity of the interstitial fluid? Yes, perfect. You're perfect with this concept. Okay, in which part of the renal tissue is the osmolality of the interstitium the highest? The renal tissue. So at this point, we're talking about outer cortex, and amazing, perfect. Which part of the medulla specifically? Is it the outer medulla or the inner medulla? Inner, amazing. This is such a high yield concept, by the way, that I've seen asked a lot. So know that the higher interstitial osmolality is in the inner medulla. Okay? Okay, we finished the first part, first concept, basically, which is like the bulk of the lecture. Now everything else makes so much more sense. So, okay, moving on to the next. If you have any questions, by the way, feel free to ask. Okay, now we're moving on to the concept of antidiuretic hormone. So, antidiuretic hormone is a very lovely enzyme, hormone, in that the name literally tells you what it does. So, anti basically means against. Anti means against. Urination or uretic means urination. So it's literally a hormone that is against urination. How is it against urination? It basically helps you to retain more water or absorb water. So it takes it takes water out of the tubular fluid into the plasma. Okay, so it helps to concentrate the urine. So antidiuretic, it's like against pee, if you want to think of it like that. My friend said that to me earlier today, and it stuck with me. So antidiuretic basically helps to absorb water, okay? So it doesn't want you to like pee too much, basically, or urinate too much. So it limits the volume of urine, and it makes it more concentrated. So think of it like you didn't drink enough water or something, or you're very dehydrated. So your urine is going to be very concentrated, and it's going to be very minimal, not as much as if you drink a lot of water, okay? So this is what we're going to be looking at. So basically, this is everything we talked about over here. We're not going to be looking at that here. For now, our focus is this part of the nephron, okay? Which is the distal tubule and the collecting duct. These two parts of the nephron are the most sensitive to antidiuretic hormone. Okay, this is where antidiuretic hormone has the highest effect. So what did we say antidiuretic hormone does? It absorbs water, okay? So if you have antidiuretic hormone and it's functioning as it should, what's gonna happen is this, sorry, let me just delete this fluid that is leaving the ascending tubular, the ascending limb, it's 100 milliosmoles, right? If it comes into the distal tubule, what is it gonna do? Water is gonna leave, okay? Because we have antidiuretic hormone. So antidiuretic hormone is gonna push water out of the tubule and thus concentrating it even more. So it's gonna increase the osmolarity. Okay, now keep in mind, remember, our whole point of doing this whole thing, this whole lecture is about concentrating urine. So obviously we don't want this urine, this fluid that we formed here, we don't want that to be what goes into the urine because that is just too dilute. We're gonna be secreting so much water. Like it's even less than plasma. So we're gonna be secreting even more than 4 liters probably, which is like way, way too much. We don't want that at all. So this whole segment, the point of it is to concentrate the urine even more. Okay, so this is what happened here. This 100 milliosmoles became 300 milliosmoles. Why? Because we removed water from it. Okay, clear? Now the fluid is going to keep going into the collecting duct, and it's going to be getting even more and more and more concentrated because antidiuretic hormone works the strongest in the collecting duct. It has the highest effect in the collecting duct, although it is also found in the late distal tubule. It is the most in the collecting duct. This is very, very, very important to know. Okay, and also notice that the cortical, you know how the collecting duct has like 3 parts? You have the cortical collecting duct, medullary, and then the inner medullary collecting duct. The cortical part does not have ADH. So ADH does not even act here. It doesn't really contribute much to like reabsorption of water. So as you can see, like the 300 that was here, it literally passed by here and it stayed 300. It was the same. It only started to get more concentrated and reabsorb more water when it reached the like medullary collecting duct. Okay, so here we formed very concentrated urine by the help of antidiuretic hormone. And everything that I just explained is, yeah, it's basically here. So as I said, the tubule fluid is hypoosmolar as it reaches the late distal tubule. This is what we talked about earlier. The fluid that basically when we were in the ascending limb, it was 100 milliosmoles. So it's hypoosmolar to plasma as it reaches the distal tubule. And then if ADH is present, the function of ADH is to absorb water. So water is going to basically like go out of the tubule into the interstitium. Oh yeah, wait, I forgot to mention this, I'm sorry. So basically it's going to, water always moves until it reaches equilibrium. That's the same thing that we saw in the descending limb in the interstitium. Water kept leaving until it reached equilibrium. So that's exactly what happens with ADH as well. So if you notice, here you have 300 milliosmoles. Let me delete again. Here you have 300 milliosmoles. If you notice, it's over here in the renal tissue. It's also 300 milliosmoles. So it basically is trying to equilibrate with that. And again, 500 milliosmoles is trying to equilibrate with this. 700, 700, 700, 900, 900. This again helps you like make sense of why we wanted to create a hyperosmolar interstitium. This whole thing here, this gradient that we wanted to form of having the highest concentration or osmolality be in the inner medulla is literally because the collecting duct, the last part of the collecting duct, which is going to go into the urine, is like at the same level of the interstitium, which is like the interstitium that is between the loop of Henle. Okay, so yeah, so here we have 1,100, and it is also equal to the renal in the osmolality in the surrounding tissue. Okay, so it basically it cannot get more concentrated than 1,100. That is the most concentrated it's gonna get because the surrounding tissue has an osmolality of 1,100. So water only leaves until it reaches that equilibrium. Okay, is this clear? Perfect. Okay, so again, this is everything that I already mentioned. As a result, the osmolality of the fluid at the end of the collecting duct approaches the osmolality of the interstitial fluid at the deepest part of the medulla. Yeah, that is just what I said over here. Okay, so all the time in first year, I would be wondering, like when I was taking this, I was wondering why we have to go through the whole process of making a hyperosmolar interstitium when the whole point is to make concentrated urine. Like, why weren't we just concentrating it from the beginning? Like, why did we have to first form a hypoosmolar fluid and then make it more concentrated? Like, that made no sense to me. But once you think of it this way, that by the end of the collecting duct, the fluid is going to want to equilibrate with the deepest part of the medulla, this makes sense. This makes perfect sense. Because we don't want, if we had a low osmolality here, in the inner part of the medulla, if we have a low osmolality, we're going to have dilute urine. That's how it is. Okay, so I hope that like clears up and you didn't have that same thought process as I did. Okay, now we're just looking at the same thing, but ADH is not working. So ADH is not working here. You either have a deficiency or you have like a receptor problem or you're whatever it is. Or you're just like you're dehydrated. So basically this down regulates your receptors. You don't really have to know all this, but just to make sense of like when you would even have an ADH or you wouldn't have ADH working. It's basically like that in cases of dehydration, basically, where your body, or no, not dehydration, sorry. Like, yeah, dehydration, sorry. So when you have dehydration, basically, you don't want to retain more fluid. So antidiuretic hormone is not going to be working and it wants to release more and more fluid from your body. Okay, so again, let's look at this. We have 100 milliosmoles leaving the ascending fluid and it goes into the distal tubule and it stays at 100. Here it stays at 100 because water is not able to leave. Okay, but if you look at it here, once it goes into the collecting duct, it actually starts to decrease. It becomes even more and more dilute. But there's still no ADH. So why do you think that is? What do you think is contributing to making it more concentrated? Even though there's no ADH, there's still no water leaving. It's the exact same thing as here, except there's one extra thing that's happening here. Can you guess? We're at the collecting duct. Okay, so if you kind of think about the previous lecture, tubular functions, what do you have in the collecting duct? Exactly, perfect. So this red arrow here is showing you that salt is being reabsorbed. So not only are you not reabsorbing water and it's staying in the tubular fluid, but you're also removing salt. So this just makes it even more and more and more dilute. So as you're going down the collecting duct, it gets more dilute. And over here in the distal tubule, there's no change. It just stays the same. Because all you're changing is you're keeping the water within you. You're not able to absorb water, basically. But no solutes are leaving. Actually, maybe solutes are leaving. Yeah, okay, wait. There's an arrow here. I guess solutes are leaving here. But the point is, two things contribute to making it more dilute. It's no ADH, so water reabsorption is not taking place. So you have more fluid in the tubules. And second of all, solutes are being reabsorbed because you have like the sodium channel in the collecting duct, and this basically helps solutes to leave the collecting duct, go into the plasma, and make our fluid more concentrated or more dilute. I'm sorry. So it becomes more dilute at this point. Is that clear? Okay, perfect. So again, everything that I said in words, I don't think I missed anything. Yeah, this is basically what I said. Okay, pop quiz. The osmolality of the fluid at the end of the collecting duct approaches the osmolality of the end of the collecting duct. So you're close. You're almost gonna excrete it as urine. Perfect. The interstitial fluid at the deepest part of the medulla. So like this part. The interstitial fluid at the deepest part of the medulla, it's gonna approach that. It's gonna approach the same osmolality because it wants to. Water always leaves until it reaches an equilibrium. Okay. In the absence of ADH, what contributes to the decrease in osmolality of the fluid in the collecting duct? If we don't have ADH, we already know that if we don't have ADH, water is not going to be reabsorbed. But what makes it decrease? What makes the osmolality decrease? Salts. Amazing. Sodium channels that cause salt reabsorption. Because if you think about it, if you only didn't have ADH, the osmolality would just stay the same. It's not going to increase, but it's not going to decrease either. It's just going to stay the same. So salt is what actually makes it decrease. Okay? Now we're just going to be talking about urea. So where specifically urea gets reabsorbed and secreted. So urea is it's an interesting substance. It gets reabsorbed in certain parts of the nephron, and then it gets secreted in other parts. So 50% of it gets reabsorbed in the proximal tubule, and then 60% of it gets secreted in the loop of Henle, and 70% gets reabsorbed in the collecting duct, and then 40% gets excreted. The main thing that you want to take from all of this is that 70% is reabsorbed in the collecting duct. So the majority of urea is reabsorbed in the collecting duct. Now, something to note is ADH, antidiuretic hormone. It absorbs, we know that it reabsorbs water, right? It also actually plays a role in reabsorbing urea. So this should make perfect sense since we have the most ADH, or the effective ADH is the highest in the collecting duct. So urea is reabsorbed the most in the collecting duct. This is an extremely important concept, by the way. I've seen it so many times asked by Dr. Shams himself. Where is urea reabsorbed the most? It's probably going to be a TBL question next week too. Come on. So yeah, most urea is reabsorbed in the collecting duct. This is like the main thing that you have to know here. Again, this is everything that I already mentioned. And yeah, urea is going to be reabsorbed. So we know that urea is reabsorbed. How is it reabsorbed? Through paracellular and transcellular pathways. So either in between two cells, it just gets passively absorbed, or within a cell itself, like through transporters. And we're going to look at that. And then you also have the mechanism of solvent drag. This is really not important at all, but it was mentioned in your slides, so I mentioned it. Solvent drag is basically just when water moves, sometimes it just takes solutes with it. Like it's the nature of water. If it's in a solution and there's water and many solutes, if water leaves, sometimes it just takes some solutes with it. That's why they call it solvent drag. It's just like dragging some solutes with it. So this also contributes to urea reabsorption. Again, I wouldn't really focus too much on this. Okay, now let's look at the transcellular transport of urea. So this is the diagram on Dr. Shams's slides. So as you can see, here you have the blood, and then here you have the tubular fluid. We're just like trying to orient ourselves. This is the cell, so of the nephron. You have the cell of the nephron, and then on one side you have the blood, and on another side you have the tubular fluid. You have 3 different transporters that can carry urea, okay? One of them basically carries urea from the blood into the nephron in Henle's loop, okay? Now, again, if something is moving from the blood to the nephron, we already know this is reabsorption. So I added this myself just to help you like think of it better. So it gets like reabsorbed. So this is how things get reabsorbed in Henle's loop. Wait, sorry. Okay. No, wait. Oh, wait, sorry. I flipped it. This is supposed to be secretion. Because we're moving stuff out of the plasma. I'll fix that before I send you guys the slides. I'm sorry. Okay, so when things are going from the blood to the tubular fluid, we call that secretion. Okay, so this would be in Henle's loop. And we already know that in Henle's loop, we have secretion. We have secretion of urea. So again, this makes sense that in Henle's loop, we're going to have these UT2 transporters, and they're going to be moving urea from the blood into Henle's loop. Okay, and both of them, by the way, on both membranes, they're called UT2. This might be asked about. I'm not too sure. Just make sure you know it. Make sure you know what the transporter is called. So the one that carries urea into the nephron is called UT2, urea transporter 2. Okay, and it's the same one. They're both UT2. This one's UT2 and this one's UT2. Okay, so this is what we call the basolateral membrane, by the way. Sorry. So yeah, this is the basolateral membrane. Like this whole thing here. This is what we call the basolateral membrane. And this is the apical or the luminal membrane. Dr. Shams used the word luminal, so yeah, so it's the luminal membrane on this side and then the basolateral membrane on this side. So know that UT2 is found on the basolateral membrane. And if you have a hard time remembering basolateral, B, blood, closer to blood, basolateral. Yeah. And then as for the movement of urea from the collecting duct into the blood, which we said is absorption, this happens with different transporters, okay? So we have UT1 and UT4, okay? So UT1 is found in the apical membrane and UT4 is in the basolateral membrane. Again, Dr. Shams used the word luminal, so I would focus on that more, just in case. You can remember UT1 being on the apical because A is the first letter of the alphabet. So you have UT1 on the apical membrane or the luminal membrane, and UT4 on the basolateral membrane. Oh, also you can remember UT2 being for secretion because a flipped 2 is an S. That's how I remember it. So if you want to think of secretion, you know that it's going to be moving from the blood to Henle's loop. So since we're secreting, which transporter do we use? UT2. And you know that UT2 is the same on both membranes, basolateral membrane and the apical membrane. So you already know all the transporters just by these little like mnemonics. Okay? So yeah. Again, everything I already said. No, not gonna repeat it because I said all of it. You can go through it. Okay. Again, this is just a schematic of urea permeability throughout the nephron. As you can see, it is permeable in Henle's loop, but it is the most permeable in the collecting duct, as I said earlier. It's the most permeable. And again, it's the inner medullary collecting duct to be specific. Okay, as you can see, the cortical collecting duct is not permeable to urea at all. Oh wait, sorry, I just circled it the wrong place. You get my point. So the inner medullary collecting duct is just not permeable to urea. So the highest urea permeability in the nephron is in the inner medullary collecting duct. Okay, the inner medullary collecting duct. And what happens here? Reabsorption or secretion of urea in the collecting duct. In the collecting duct, do we reabsorb or resecrete? Yeah, exactly. We reabsorb urea here. And in Henle's loop, it's responsible for secretion. But again, as you can see, yeah, secretion. As you can see, it's not as permeable as the collecting duct. So don't get confused. What is the most permeable? It's the inner medullary collecting duct. Only that, okay? Not only that, but that's the most. And that's probably what's going to be asked about. Okay. So yeah, this is Again, everything that I explained, the inner medullary, descending and ascending limb have a higher permeability than the outer medullary descending limb. As I said, everything inside is just more permeable. Cortical medullary collecting duct is not permeable at all. No reabsorption in the distal tubule and cortical collecting duct. So in the distal tubule and the cortical collecting duct, this whole part, there is no reabsorption at all. Again, I would know this just in case that there's no reabsorption here, but I've never seen a question asked about it, and I don't think it's going to be asked about this. Everything in the slides, make sure you know it. This is everything that was in Dr. Shams's slides, everything that you need to know. So go over it. I did go over all of it, and I explained all of it. Okay, so now we're looking at basically the effect of ADH throughout different segments of the nephron. Okay, so we're going from the beginning of the nephron all the way to the end. So we're looking at the effect with ADH and without. When we have ADH and when we don't have ADH, or ADH is not exerting that much of an effect on the nephron. Okay, so we start off. I'm going to explain first with ADH. Okay, so we're going to look at this line over here on the top. This is the effect with ADH. Okay, so in the proximal tubule, we'll start from the very beginning. In the proximal tubule, as you can see, there is no effect of ADH. Okay, so there is no ADH effect here. So as you can see, the osmolality is staying constant with or without. It's at 300 milliosmoles. This is in the proximal tubule. Now moving on, we go into Henle's loop. Now in Henle's loop, as we know, the osmolality increases as we go along Henle's loop, and then it starts to decrease as we leave Henle's loop. So this is what's happening over here. Osmolality is increasing and it's going down. Okay. Now, as you can see, by the way, this is the effect of ADH in Henle's loop. There is an effect of ADH, but it's very, very minimal that we don't really consider it, okay? Because the major effect is later. So over here, we're basically just talking about, we're just basically looking at, in a normal case, basically, in Henle's loop, the osmolality is going to increase and then it's going to go back down. And then you go into the late distal tubule, or distal tubule, early distal, late distal tubule, whatever. So you're in the late distal tubule. In the late distal tubule, the osmolality is still low, but this is when ADH basically starts like having a role. So it's going to start to, let me just change the color. So over here, it's going to start to increase like steadily, but it's not going to increase too much. But ADH is working to absorb more water. It's retaining more water, okay? So as you're going up here, you're concentrating. Okay, so over here, we're concentrating the urine even more, as well as we are increasing, in other words, we're increasing the osmolarity or osmolality. Okay? So this is why in the distal tubule, we're basically increasing the osmolality as we go along it. Okay? And then we reach the collecting duct. And as you can see in the collecting duct, this is where you have the maximum effect of ADH. In the collecting duct. This is very, very important. And again, I talked about this earlier, but this shows you very clearly that with maximum, when you have like the maximum effect of ADH, this is in the collecting duct. Okay? And as you can see, once we reach the very end, we have reached a osmolality of 1,200. Now I told you, you cannot go beyond that. That is like the maximum concentration of urine that you can have. Okay, so here basically you have like less urination, okay, or antidiuresis. So here we have antidiuresis. So we're urinating less basically. Okay, when we have the highest osmolality, the urine is very concentrated and it's very minimal in volume. Always relate those two together. Okay, this is in the case when we have ADH, when ADH is working. Okay, so again, this case, this also could be when you are like a physiological state that you could be in to reach antidiuresis is if you are dehydrated. Okay, so if you're dehydrated and you're not drinking enough water, ADH is going to be at maximal effect. It's going to be working the hardest to try and retain more and more water in your plasma. So it's not going to be in the urine because it wants to keep it in. You're already not, like, you're not drinking enough water. So the least the body can do is retain the water that it already does have. Okay? This is what happens with ADH. Now let's just remove all of this and look at how it is without ADH. Okay, the other line is without ADH. Okay, so again, in the proximal tubule, it's the same. It's 300 milliosmoles. As you're going into the loop of Henle, again, it's increasing. It's still like, it's increasing, just not as much as it did with ADH. Because like I said, the effect of ADH is not very significant over here. So again, it's going to increase. And then once you go into the late distal tubule, this is when it actually starts to get like less, way less. Why? Because when you don't have ADH, you're basically allowing more water to be excreted with the urine. You're not holding on to more water. No, like ADH is not doing its job, which is retaining more water. It's actually allowing water to like stay within the tubular fluid and move along the nephron and go into the collecting duct. So as you can see, this is very like perfectly depicted here. The osmolality is decreasing as you go to the distal tubule and you reach the collecting duct in urine. It is a very, very low osmolality. So it doesn't reach 0. I believe it's like 0.1 at the very end over here. It's like 0.1. Okay, it's not going to reach 0, I think. But this is without ADH, okay? So when would you not have ADH? Basically, if you are drinking a lot of water, okay? So hydration. So when you're drinking a lot of water, you already know, if you're drinking a lot of water, you urinate a lot, right? And your urine is very clear. So it's not concentrated. So this is what's happening without ADH, or like what you can correlate with not having ADH. If you don't have ADH, basically your body doesn't want to retain more water. Okay, it already is getting supplied enough by the water that you're supplying it with by drinking water. Okay, so the more hydrated you are, the less the effect of ADH becomes important. You don't really need ADH when you're already drinking a lot of water. Your body is already like happy with the amount of water that it has. It doesn't really want to retain more water. It's happy to give its water to the urine and like let it leave. Okay, so this is what's happening here. Any questions about this entire graph? You guys understand? Is it clear? And again, we said, by the way, this was antidiuresis. So this is when you're urinating less. And over here, this is diuresis. This is when you are maximally urinating. Okay, so here you have maximum diuresis. Here you have maximum antidiuresis. Is that clear to everyone? Okay, I'll hope that's a yes. If you guys have any questions, please let me know. Okay, so again, this okay, if it's without ADH, that means no reabsorption of water. Yeah, exactly. If you don't have ADH, you're not reabsorbing water, so water stays in the urine. Or it stays in the tubular fluid, and therefore you have more water going into the urine. Clear? So less concentrated urine, exactly. Urine will be very dilute. Again, think of it like you're drinking a lot of water or you're not drinking water at all. When you're drinking a lot of water, your urine is a lot in volume and it is very dilute. So it's low in osmolality. It's very dilute. It has a lot of water. Okay? And the opposite for when you're dehydrated. If you're not drinking enough water, ADH is going to work the most to retain more water and reabsorb more water, and therefore creating a concentrated urine with a high osmolality. Okay. Again, makes so much sense. Okay, I'm back from there. Okay, so again, this is what we said in water restriction. If you're not drinking enough water, the kidney is going to maximally concentrate the urine. Okay, because and it excretes a minimal volume of water. Antidiuresis. This is very like self-explanatory when you think of it in the sense of you drinking enough water or you not drinking enough water. If you're in a state of water restriction, the kidney is gonna want to concentrate the urine even more because it doesn't want to lose more water. Okay. On the other hand, ingestion of excess water causes the kidney to produce a large volume of dilute urine. Same thing I said earlier, you're drinking a lot of water, you're excreting a lot of urine, and it's also very dilute. So it's very transparent, or not transparent, it's very, yeah, it's transparent. Like if you drink a lot of water, yeah, it's, yeah, white, sure. I think transparent is the word. So yeah, transparent. So yeah, it'll be very transparent. It'll be very, like a lot in volume as well. In both cases, the tubule fluid does not change in osmolality along the proximal tubule. As we said here, it does not change. And then, and it still becomes hypotonic to plasma by the end of the thick ascending limb of the loop of Henle. So even though the loop of Henle, as I said, it does have an effect on it. ADH does affect the loop of Henle just very minimally. It still gets, by the end of, this is the end of the loop of Henle, over here. The end of the loop of Henle, as you can see, it's still less than plasma. It's at 200. Plasma is at 300. So it's still less than plasma, regardless of whether ADH acted on it or not. Okay, so this is very important. This is why we say that it doesn't affect it that much. If it did affect it, it would make a difference if whether, let's see, if we do have maximum, this is the effect with ADH at the end. Okay, it's like right here. Sorry, it's like right here with ADH. And without ADH, it's like right here. Or like, sorry, that was a very bad estimate. It's like right here. So regardless, it's still less than the osmolality. So it really doesn't make a difference. With the collecting duct in urine, it actually does make a huge difference. And it affects whether or not we make a hyperosmolar urine or a hypoosmotic urine. Okay? This is the main takeaway from all of this. Okay. Again, I also explained all of this, but I'll just go over it just to make sure. So the fluid entering the distal convoluted tubule is always hypoosmotic with respect to plasma. Basically, this is just saying, in other words, the fluid that is leaving the ascending limb or entering the distal convoluted tubule, it's always going to be hypoosmotic, regardless, because again, ADH is not really a major factor here. Okay. Under conditions of restricted water intake, elevated levels of ADH, increased water permeability. Okay, I explained all of this, so I'm not gonna just read it. Okay. Again, collecting ducts, in the collecting ducts, the osmolality increases as the tubule fluid equilibrates with the surrounding medullary interstitium. Medullary interstitium becomes increasingly more hyperosmotic because this is when we have ADH basically. It becomes even more hyperosmotic because ADH stimulates urea absorption. Again, this is like I said, I told you this earlier, but ADH actually has an effect on urea reabsorption as well. So, which is why I told you urea reabsorption is the highest in the collecting duct because ADH works most in the collecting duct. Okay, so urea reabsorption by the medullary collecting ducts. Again, this is very important. Eventually, the tubule fluid reaches an osmolarity that is as much as 4 to 5 times higher than the osmolarity of plasma. Okay, so this is the goal when we do have ADH. We basically want to create a very high osmolality that is higher than plasma. Okay, and it's about 4 to 5 times. So I think it was like the osmolality of plasma, like actually is 280, and then the maximum is like 1,400. The osmolality that we want to reach. It's like 4 to 5 times higher than it. Okay. Yeah, the medullary collecting ducts are responsible for concentrating the final urine. This is because they're the final destination of urine before it leaves and it goes like outside the body. Okay, so these are responsible for concentrating the final urine, and it's the site of the highest osmotic pressure in the presence of ADH. So this is why in ADH, most of the water that's going to be reabsorbed if we do have ADH is in the medullary collecting duct. Again, this is very important because in the cortical collecting duct, it's not this way. It's in the medullary collecting duct where we have the highest osmotic pressure. So water movement is the highest in this point when we have ADH. Therefore, water is being reabsorbed. Okay? Okay, in the absence of ADH, very little or no water will be reabsorbed, and thus creating a diluted urine, which is hypotonic to plasma. Okay, so if it has a lower osmolality, again, it's less concentrated or more dilute. And this is when we don't have ADH. So ADH is no longer retaining more water for us. Okay, that's it. That's this concept. Is this clear? Everything about ADH, the effects of it. This is very similar to it, by the way. Okay. Now we're moving on to diuresis and antidiuresis. I already sort of touched upon this, and this will make this graph so much easier for you guys. So again, it is a very similar graph, except here we have the segment of the nephron. However, in the y-axis, instead of having osmolality, here we have the GFR basically. So the amount of fluid that is reabsorbed. Now you know this from previous lectures, but basically, most fluid gets reabsorbed in the proximal tubule. I think it's like 65%. Yeah, 65%. So 65% basically is getting reabsorbed over here in the proximal tubule. And then it goes on to here, 35. Yeah, so we already have like, this is only 35% of the fluid. So only 35% of the fluid reaches the end of the proximal tubule, okay? Because it's like 100 minus 65. This is basically what they did. So basically, by the end of the proximal tubule, you only have 35% of fluid to concentrate or to dilute, okay? So you're moving on even more, and by the time you reach the late distal tubule and the collecting duct, you only have 20% of fluid. So basically what they're trying to tell you is ADH only has its effect on 20% of the GFR. All of this is already like, it gets reabsorbed without the help of ADH. Okay, so ADH only contributes to this 20%. So even that whole graph that we saw earlier with like ADH effect, it's only affecting 20% of GFR. Okay, so over here, once we have 20%, some of it is going to be in the control of ADH. Some of it, I don't know why I made an arrow. Some of it is going to be under the control of ADH. Some of it is going to be, there's not going to be ADH acting on it. So which one do you think has ADH? Is it this one or this one? It has ADH. The upper one, exactly. So here we have ADH. Here, the effective ADH is taking place. Here there is no ADH, okay? So no ADH, therefore, we said it was maximum antidiuresis. So it's basically when we want to retain more water. And it's gonna make the, okay, here we have, let's go up first. Okay, so here when we have ADH, basically it's like, wait, you saw the upper one? No, wait, it's the lower one. When we have ADH, it's the lower one where we have antidiuresis. Okay, remember, antidiuresis is when we don't want to urinate even more. Yeah, I'm sorry. Okay, so when we have antidiuresis, this is when we don't want to urinate even more. We want to retain ADH. Okay, so over here, the lower one is the effective ADH. Okay, here we have ADH. I'm really sorry for the confusion. Here we have ADH, and then over here we don't have ADH actually. Here there is no ADH being deposited. So our urine is more concentrated over here. So no ADH, concentrated urine, and osmolality, would it be high or low? High, exactly. So here we have a high osmolality. These all pertain to this case where we have maximum water diuresis. Okay? Diuresis, just think of it like very logically, diuresis is urinating. So when you would be urinating more, you don't have ADH. You don't have ADH, so you don't want to retain more water. You're actually losing more water. Okay, so this is maximum water diuresis. This is when you're basically losing the most amount of water. Okay. By the way, this is, if you want to like look at the other graph, it's basically this point. It's this point here, like as we like when you don't have ADH, basically. Okay. Okay. And then over here, yeah, it's maximum antidiuresis. So basically, you don't want to urinate even more. So ADH is going to be like holding in more water, and the urine is, yeah, antidiuresis is when you do have ADH. Yeah. So you do have ADH, and so you're basically holding in more water, and so the urine over here is, let's just write it again. You have high ADH. You have high ADH. Your urine is dilute at this point. It's dilute. It has a lot of water, and it is has high osmolality. Yeah, you have low osmolality. Okay, here. Yes, question. Oh my God, I'm so sorry. I'm so sorry. Wait, I closed something. Okay, if we have diuresis, that means we take in more water. No. If we have diuresis, that means we retain more water. Or no. If we have diuresis, basically you're urinating more, so you're not taking in water. Like ADH is not having an effect. Because ADH is anti-diuretic. Yeah. So shouldn't the urine be dilute then? Oh yeah. Yeah. It will be dilute. I'm sorry. You're right. So we're not gonna have ADH, but the urine will be dilute. Yeah. You are completely right. If we don't have ADH, we have more dilute urine, and we have a lower osmolality. Okay. Again, if you have low, and then if you do have ADH, basically you have a concentrated urine. It's a very, very good catch. Thank you so much for catching that and correcting me. And then you have a higher osmolality. Okay. So yeah. Is that clear? So again, like the major takeaways from this slide is that ADH has its effects mostly on the late distal tubule and the collecting duct. And the proximal tubule, like early on, it's mostly under the control of like other things, and most of it is reabsorbed. How much of it? Like 80%. 80% is already reabsorbed over here. Okay, so only 20% is under the control of ADH. Okay, and again, when you have maximum water diuresis, or in other words, when you urinate the most, and it's the most dilute urine, here ADH has minimal effect. Okay, so this is minimal effective ADH. This is maximum effective ADH. Okay, when ADH is at maximal effect, it's going to concentrate the urine, and it's going to increase the osmolality of it. If ADH is not working, it's going to dilute the urine even more, and it's going to decrease the osmolality. Does that make sense? Okay, perfect. So again, diuresis, antidiuresis. This explained all of this. You can read it. And yeah, the 20% only is dependent on ADH. Again, everything I explained, you can have it in word form. Okay. Moving on to like the end pretty much of the lecture. Over here, he just gave you some normal values, and I wouldn't say they're too important, but again, the urine flow, basically, the average urine flow is 1.5 per day. So this is how much urine that you want to excrete per day. If you have dehydration, again, your body is going to want to retain more water. So in dehydration, you have ADH. You have lots of ADH, basically. So your body's going to want to retain more water. So you have a very low volume of urine, okay? 0.3. And if you have extreme water intake, you're not going to really need ADH that much because you don't want to retain more water. So you have a low ADH or low effective ADH, and your urine will be the most in volume, okay? Which is going to be 16. So basically, like, the maximum value of urine that you can have is 16. The lowest is 0.3. I don't think there is like anything else that he wants you to know from this. He didn't have anything in the notes section either, so I think this is just what the takeaway is. Okay, and then here, the ability to produce concentrated urine, and I also don't really think this is that important, but basically what you can notice here is showing you like different animals and the concentration of their urine. And basically what this is just showing you is like the effect of climate. So as you go down, basically the climate is hotter. So a desert spring mouse lives in a desert. So what is it going to want to do if it lives in a desert? Can you like predict? Lives in a desert. Often you associate like a desert, a hot place with dehydration. So it's going to want to, yep, exactly. So a desert spring mouse would want to retain more water. That's why we see the most concentrated urine over here. Exactly, yeah. Most concentrated urine and highest ADH and the highest urine to plasma ratio. So basically like so here basically it's 25. That means that this is 25 times more than plasma. The urine would be 25 times more concentrated than plasma. Okay? And again, with humans, this is mostly what we're concerned with. Humans, as I said, the maximal concentration of urine that you can obtain is 1,400, and it's about 5 times as much as plasma concentration. Okay, so again, plasma osmolality is about 280 if you're exact. And the lecture he says 300, but it's about 280 actually. And so if you multiply that by 5, you should get 1,400. So this is just basically what it's telling you. Again, I really don't think this is that important. You guys understand? This is our final checkpoint. You guys have any questions before we go into the practice questions that I have prepared for you guys? If you have any questions, please let me know. Don't want me to re-explain any concepts, please let me know. Okay, then. I'm going to assume there's no questions, and we're going to go into practice questions. I have about 6 over here, so hopefully we'll get through them easily. Okay, so number 1, which of the following segments of the nephron is least permeable to water in the presence of ADH? Least permeable. Basically, where does ADH not have an effect? Or no, not ADH. It doesn't even have anything to do with ADH, by the way. It's just telling you that to like throw you off. Literally just, what is the segment of the nephron that is least permeable to water? See? Does anyone else want to answer? I'll just wait to see if there's more answers. Okay, yeah. So the correct answer is C. It's the ascending loop of Henle. By the way, this is a past question. I got a few past questions and a few from books just to keep it like have a nice variety. Okay, now number 2. Urea is a key component of the urinary concentrating process. In which part of the nephron is the permeability of the luminal membrane to urea the greatest? Where do we have the highest urea concentration? Or not concentration, permeability. I talked about this a lot. Okay, I got an A. Does anyone else have another? Okay, wait. Just be careful. We're talking about urea, okay, not water. You remember that diagram that we showed of urea, and it showed. I'm gonna show it to you again after this, since we got a little confused. Where is urea permeability the greatest? Yeah. Is it E? Yes, it's E. Okay, I'm gonna go back to that slide showing you guys the urea concentration, because I really, really don't want you guys to forget this, okay? So this is showing you, sorry, not this, here. Over here we have, yeah, okay. Okay, so this is the permeability to urea, okay? Really, all of this just by this diagram alone, you can tell that urea is most permeable over here in the collecting duct. Okay, there's also, I think, another diagram, yeah, over here. Actually, no, this doesn't really show permeability. But yeah, this shows permeability. Highest permeability is in the collecting duct. Where is it also permeable? It's also permeable in the loop of Henle, but it's not the most at all. This is clearly the most. Like you can see the magnitude of that. Okay. I don't want to spoil anything. Okay, is that clear for everyone? Okay, yeah, please do remember that. As you can see, it is a past question. So, and it was asked a lot. Like I saw it, I put it once, but I saw it a lot, by the way. Whether it was in TBLs, finals. So, permeability of urea. And it's also in Dr. Shams's practice questions that he sends you guys, like the quiz. I don't know if he sent it to you guys yet, but from like previous ones. Okay, next question. Here it's getting a little long. Oh, he didn't send it to you yet? Okay, once he sends it to you guys, make sure you solve it. It's actually like very helpful. And he gets questions from it in his TBLs and like exams. Sometimes. Okay. Next question. This is really long. Does anyone want to read it, or I skipped like asking you guys because I know most people don't like to read. Okay. Oh, you don't have a mic? Okay, that's fine. I'll read it. Okay, so a 70-year-old male lives alone and reports that he gets up from bed several times to urinate. Okay, so we have like high urination. He was tested for his ability to concentrate urine maximally by a simple water deprivation test. Okay, so they thought, okay, he's urinating a lot. Is he unable to concentrate urine, or what's the problem exactly? So this is what they tested him for. And then it was found that his maximum urine osmolality was only 300 milliosmoles. Okay, so it's okay. Wow, that was fast. Okay, let me just continue. I thought it was gonna be hard. That's why I'm like elaborating a lot. Okay, so his urine osmolality was only 300 milliosmoles. Okay, so that's very low when we're thinking about urine. We want it to be higher. We want it to be more concentrated. Okay, even though his ADH levels were high, so he did have ADH. He had the ability to like retain more water and concentrate his urine, but his urine was still very dilute. Okay, so this indicated a problem with what exactly? Impaired ability, which of the following could account for his impaired ability to concentrate urine? So if it's not ADH, okay, someone answered. Does anyone have any other answers before I reveal the answer? Okay, I got 2 Ds. That's good enough for me, and that is correct. The answer is D. So again, if someone doesn't know, ubiquitination basically means it gets tagged for degradation. So ubiquitin is a protein that tags things and basically is like, okay, I want this to be degraded. So it gets degraded. So if you have UT1 ubiquitination, if it gets degraded even more, basically we said that urea, it gets like this helps in the urea, like urea helps to concentrate urine even more. Okay, so if we don't have transport of urea, this is a urea transporter, if you remember. If we don't have the transport of urea, we're gonna have very dilute urine. Okay, so even though we have ADH, if there's a problem with urea, we could end up with dilute urine. Okay. Okay. Next question. So a patient with food poisoning presents to the emergency department after 24 hours of vomiting and diarrhea. Vomiting and diarrhea. The patient is dehydrated. So intravenous therapy with normal saline is started. Which of the following correctly describes his renal function during the period of dehydration? So what happens in a period of dehydration? Okay, perfect. I got 2 A's. Correct. The answer is A. Does anyone want to explain why the answer is A? Rod, you can type it in the chat. There's high tonicity because the body needs to hold on to more water. Okay, high tonicity where? Yeah. Yeah, exactly. But where? Is it in the interstitium or is it in the tubular fluid? High tonicity where? Yeah, the interstitium. Okay, so again, we have the loop of Henle, and then you have the vasa recta like surrounding it. And so when we have a high tonicity, so let's say we have a lot of sodium here, basically the vasa recta is going to be taking in more solutes. So the blood volume that leaves the vasa recta is more than the ones that are entering them. So basically the vasa recta is going to be carrying out more solutes. Like so the urine is going to be more dilute, and the patient is going to be more dehydrated, okay, because the patient is losing more water. Okay. So next question. Which of the following statements is true? So take your time with this one. D again. Okay, anyone else? I think it's D2. Okay, and you guys are both correct. So yeah, the osmolarity of the fluid in the early distal tubule would be less than 300 milliosmoles because we said that the fluid that basically enters the early distal tubule, the fluid that leaves the ascending tubular fluid and goes into the early distal tubule is always hypoosmotic. It's always hypoosmotic, okay? It's hypoosmotic. So it's hypoosmotic, it's less than 300. Hypoosmotic. Okay? So 300 is the osmolarity of plasma. So if it's less than that, it's hypoosmotic. Again, this is like just it's repeating the same thing. Exactly, yeah. I really hope the exam isn't as hard as this. Honestly, like you saw the first 2 questions that I got, they're much easier, right? Like this kind of tells you the exam inshallah won't be as hard. But you do want to do these types of questions, and you want to do questions from books like this because it helps you think a lot. And it helps you like try to connect the pieces and make sense of each and every option, eliminate the wrong ones. You know, like really helps you to like solidify your understanding 100%. Once you do these questions, you never forget this concept again. So even if the question is hard, it's okay, don't worry. Do it just to like use it as a learning tool to understand better. Okay, don't worry about the exam. Inshallah, you know, it'll be very easy. Session. Alhamdulillah. I'm so glad that you sent it as well. Okay, wait, there's one last question. So in the normal kidneys, which of the following is true of the osmolarity of renal tubular fluid that flows through the early distal tubule in the region of the macula densa? So they're basically just asking like, what is the nature of the fluid in the early distal tubule? This is similar to the question before. Amazing. Okay, so the answer is B. See, this is a book from Guyton, so it's still, I mean, a question from Guyton, which is still like a practice question book, and it's still, and it's simply, it's like kind of direct, you know? It's just, sometimes a question may seem long, but if you like think it through and write down the main things, like how we were doing with this really long question, think about, okay, patient is vomiting, so he has dehydration. Think about the osmolarity. Think, is it high? Is it low? Do we want to retain water? Do we want to lose water? Just have your thought process. Try to write it down on paper, and inshallah, it'll make sense. It'll make the question very simple, and you won't have a problem solving even hard questions, even if you get hard questions in your exam, which inshallah, a lot of you don't. Okay, we are done. So thank you guys so much for attending. And please scan this QR code to give me feedback if I can improve. And yeah, if you have any questions, my contact information is in the first slide. You can email me, text me, whatever you want. Any questions that you have regarding this lecture, I'm very happy to help. And yeah, good luck on the rest of the block. Inshallah, you guys will enjoy it. Inshallah, you guys will have a very easy exam and end this semester off on a good note. And inshallah, best of luck on your TBL as well. And yeah, thank you guys. Of course. Thank you for attending.